Good evening to all. We will move on to the next talk, that is Toric eye oil for beginners. I invite the panel members, Dr. Vijayalakshmi, myself, Dr. Nisha, Dr. Sugandha, and Dr. Jashina. Dr. Sugandha is a very good phacosurgeon, doing torics more frequently. I invite her for the talk on for whom you will select, for whom, which patient you want to put a toric eye oil. The details will be follows.
So good afternoon, everyone. Today, our instruction course is aimed at all the phacosurgeons who are transitioning from monofocal IOLs onto toric IOLs. And this also would be very beneficial to all the phacosurgeons who are looking to optimize their toric IOL outcomes. So let's begin with patient selection guidelines. So of course, an ideal candidate would be a patient with visually significant cataract along with astigmatism. It should be a regular, symmetric astigmatism. Always aim low, that is, beginner surgeons should always aim for correcting a corneal astigmatism between 1 diopter to 3 diopters. And always aim to have a patient who has a good ocular surface, a regular cornea on topo. That is indicated by very crisp Placido rings. And of course, a healthy tear film and a good Schirmer value. Of course, you should have a normal optic disc status and macular status to have a happy patient at the end of your surgery. And the last point that I need to emphasize over here is the patient's need to be spectacle-free for distance or near viewing, or both. So you must always optimize your surgery in such a way that you are addressing the patient's need for astigmatism correction. If the patient's requirement is a good uncorrected distance vision, whether or not the patient has astigmatism will determine whether you want to implant a monofocal IOL or a toric IOL in this case. Of course, you can also go for a multifocal toric IOL if the patient is affording, which in our scenario, a lot of patients are coming forward who are looking to optimize their distance and near vision both, be completely spectacle free. And all the phacosurgeons who are just moving on or transitioning from monofocals to toric, I would suggest that you better avoid, at least in the beginning few, say about 50 cases, until you get your hands steady, to avoid these particular conditions. These are not contraindications per se, but then you would be better off avoiding these situations like extreme degrees of zonal instability, say in case of pseudoexfoliation, say there's a history of trauma. Of course, history taking is very important in these cases. If there's an irregular astigmatism, a dense corneal scar, or progressive pterygia, or an ectatic cornea, a pre-existing PC dehiscence, PPC per se is not a contraindication. If you can get a good round central posterior capsule, which you can turn it into a PCC, go ahead and implant a toric IOL. I'm just saying that the beginners should avoid, in the first few cases, better to stay off these cases. Then advanced glaucoma, definitely, how much ever you do a good cataract surgery is not going to affect the visual outcome because of the optic disc abnormalities, like, say, if it is an advanced glaucoma, suboptimal macular health or macular degeneration because of various causes, age-related or myopic, etc. Prior VR surgeries, again, no contraindication as such, but beginners better to avoid. Prior refractive surgeries like PKP, RK, the end results or the outcomes are variable. That is why beginner surgeons, to get your feet, get your confidence, first few cases, better to avoid these cases. Previous history of scleral buckling, glaucoma infiltration, glaucoma implants and filtration devices. Also exercise caution in hypermature Morganian cataracts with sclerotic capsules, only because there can be issues with a well-centered rhexis. If you can have a standby monofocal IOL, it'll be good. In case you get a good well-centered rhexis, go ahead and implant your toric IOL, and the patient will always thank you for it. Poor pupillary dilatation cases, if you are confident with placing iris hooks or rings, please go ahead and implant your toric IOLs. But in case you're not confident, better stay away from poor pupillary dilatation cases, because you will not be able to visualize the markings, the dots or lines that are there to denote the axis. PCR on table, again, is a contraindication because if you put a sulcus implanted IOL, it always has a tendency to rotate, and I'm not aware of any 3-piece IOLs which have, which can correct toricities. Amblyopia. Now, we had a case who, of course, the patient was very well counseled pre-op, but then the patient ultimately turned out to be a little unhappy in the end, even though we had counseled pre-op that, because of the difference in the axial length, there was some amount of, it was a young patient and he was not happy post-op. So in the beginning, to get your confidence, please stay away from cases who have identified amblyopia. So history taking, again, is very important. So address potentially treatable issues like a dry eye, low Schirmer and T-butt values, meibomian gland dysfunction, pterygium, contact lens wearers. So this is a case of extreme dry eye. If you can see the corneal topography, it would look like an ectatic cornea. You can see the KSA value as 379%. But when I checked the Schirmer's value, it was very low, and T-butt was quite low. In the left, this is the topo of the left eye. So you can see the T-butt is at just 8 seconds. The same patient, after 2 weeks of topical lubricants, the cornea topo looks perfectly all right. Now this, I'll just take a couple of minutes more. Pterygium causes flattening of cornea in the same axis. So any small atrophic pterygia may not cause any significant astigmatism, but vascular fleshy pterygia, which are obscuring the visual axis, should be addressed first. And toric IOL can be planned 6 to 8 weeks later. Surgeon factors. Now, technically, toric IOL surgery is no harder than a non-toric IOL surgery. Like I suggested earlier, better to avoid certain conditions just until you find your feet into the surgical practice of toric IOL implantation. Beginner tips, of course, adequate pre-op counseling. Always take both eye measurements. Refractive status of both the eyes have to be taken into account to avoid refractive surprises like amblyopic cases and unhappy patient in the end. Understand patient expectations and requirements and match the IOL to the patient's job, hobbies, etc. Use of brochures and color topo that you can make the patient understand what you are aiming at, and select an optimal eye and the patient. Plan your surgical schedule, especially for beginner surgeons. Better to choose cases with regular astigmatism with a symmetric bow tie pattern. So biometry tips, ensure correct head alignment. Optical biometry and manual keratometry are always preferred methods. And always, if any inconsistency or varying values, always cross-check with topography and manual autokeratometry. SIA, or 2.2 to 2.4 millimeter incision, always ensures no to minimal surgically induced astigmatism, and all cataract surgeons should be aware of their SIA. So these are just to show you a young patient with WTR astigmatism and an older patient with a ATR astigmatism. Take-home pointers: aim small, miss small. So beginner surgeons start by correcting between 1 diopter to 3 diopters of astigmatism. Start with straightforward cases, a good eye, good corneal surface, good retina status, and always educate the patient about the refractive outcome and the rare possibility of re-rotation. We've had such a case, I've had such a case of rotation, which was a nightmare for me. Okay, and so realistic patient expectations, good surgical planning will lead to a good surgical outcome. Thank you.
Thank you, Dr. Sugandha, for the wonderful presentation. Now I invite Dr. Nisha for the next talk. Preoperative marking is very important in a case of toric IOL. So we will see what all things to be done in a preoperative marking.
Good evening all. Now I'll be dealing with the preoperative marking of the toric IOL. So this is to ensure that we end up placing the IOL in the desired axis. The placement of axis of placement of IOL will depend upon the precise marking of the horizontal reference axis. So there are two markings, that is a reference marking, which is a pre-op procedure, and an axis marking, which is an intra-op procedure. The pre-op reference marking is placed at the limbus in 3 locations, that is 0, 180 degree and 90 degree, and the patient is in the sitting position. Axis marking is identify the optimal axis of IOL placement as determined by the toric calculator. Axis marks are placed on the eye using pre-op reference marks for alignment of instrument. And there is some amount of cyclotorsion in the eye when the patient move up from an upright position to supine under the surgical microscope. And it can vary from 2 degree to 16 degree. Hence, it is important to mark the horizontal axis in the sitting position. So there are various methods, that is manual methods and automated methods. And the manual methods are by freehand marking, simple toric reference markers, anterior stromal puncture with staining, bubble marker, pendulum marker, and electronic toric IOL marker. And automated methods are by limbal registration, that is by Varian image guidance system and KSOS2023. Intraoperative, there is another method, it's an intraoperative wavefront aberrometry, that is by Aura System WaveTech Vision. Now coming to the freehand marking, by using a junction violet pen after topical anesthesia, when patient with both eyes open, fixation at a distant object, mark the limbus at 0 and 180 degree. Other prerequisites are, you can rest the hand on the patient's cheek to enhance the control of the marker. Check that the patient's head is not tilted left or right. Now take the marker below the eye and then move it up and straight towards the eye. The reference mark should be done on a dry eye, because a large mark from ink that smears or bleeds on the surface will cover a range of degrees, and it will compromise on the precision of the IOL alignment. And you can use speculum in cases of small palpable pictures and also in non-cooperative patients. And the prerequisites of the slip beam should be of size of 14 millimeter into 1 millimeter, and it should be oriented at 0 to 180 degree, and is focused on the corneal apex, identification of which was aided by the first Purkinje image. This Purkinje image will appear as a small cylindrical reflection of light bulb. Focusing at the center of Purkinje image ensures that centration of the slit beam. So this is the junction violet pen which we use, and it should be always sterile and pointed. Avoid the blunt tip. So this is a video demonstrating the freehand marking. Here the slit beam is oriented at 0 and 180 degree, and by using a junction violet pen, marking is done at 0 and 180 degree. So next is the anterior stromal puncture with staining. Here 2 methods can be used. That is, first is using a stain needle, 26 gauge needle. Anterior stromal puncture can be done at 0 and 180 degree just inside the limbus. Further, the patient is asked to blink for 2 or 3 times. Another method is here, there's a video demonstrating the other method. Here speculum is used, and after marking at 0 and 180 degree with the junction violet pen, um, 26 gauge needle is used to mark at the 0 and 180 degree. So this is the 26 gauge needle is used to again mark at 0 and 180 degree. And next method is by using a Cioni toric reference marker. This is an instrument which has a hemicircle ring with 3 wedges at 0, 90 and 180 degree, and it has a handle attached to it. Now it can stain the wedges with the junction violet pen and now move towards the eye, and the wedges are placed on 0, 90 and 180 degree. So this is a video showing marking by bringing the wedges in contact at 0, 90 and 180 degree. So this is an image of the eye after marking, that is at you can see at 0, 90 and 180 degree. This is a bubble marker instrument. So this is a video demonstrating. It has wedges and hemicircle ring with the wedges and a handle. There is an air bubble inside the liquid which moves to right and left on tilting, and when it is center, remains. When it is horizontal, the air bubble remains vertical to the center to the vertical line. So the method is by, like after topical anesthesia, the patient is seated in the upright position, fixed at a distant target. The markings are made at 3, 6 and 9 o'clock position. Now when the bubble is in the center of the vertical line, it is indicated that 3 and 9 wedges of the markers are truly horizontal. Gradually move towards the eye while the examiner ensures that the bubble is in the central position when the wedges make the contact with the limbus. So this is a video showing the bubble marking. So you can see the air bubble is in the center of the vertical line. Next is the pendulum marker. Yeah, this is an instrument where now the patient is asked to fixate on a distant target, and the 0, 90 and 180 degree contact wedges on a hemicircle of the device are attached to a shaft within a hollow handle to a gravity pendulum. This ensures that the wedges remain perfectly horizontal even if the handle is rotated either side. This is another instrument, that is an electronic toric marker. It marks the 3 and 9 position on the limbus. The electronic head is fitted on the body, and the marker is gradually moved towards the eye. It has a flat handle, so it ensures it gives more stability while marking. And the green light indicates that horizontal wedges on the marker are truly horizontal. And the orange light with a slow beat indicates that it is slightly tilted. Red light with a fast beat shows that it has a severe tilt. And other sources of errors are due to manual methods are smudging or fading of the eye. It can cause broad marking, and the mark can easily diffuse 10 degrees, or the mark may disappear entirely, and there's a Bell's phenomenon too. So to avoid these errors, there are automated methods. So the automated methods are by Varion digital marker, that it provides more information, like it gives automated centration, it gives an incision position, and you can avoid the pre-op marking, and also provide centration and alignment guidance for toric IOL. Thank you.
Thank you, Dr. Nisha, for that wonderful presentation on how to mark a toric IOL, for toric IOL. Now we'll see how to perform a good surgery of toric IOL implantation. Over to Dr. Seena. She is a senior consultant, phaco and refractive surgeon at Comptos Eye Hospital.
Now we will see how to do what are the surgical techniques for a toric IOL. Once you get the patient in your OT, after the marking, just see the markings are very clear and see the dilatation. If it is a well dilated pupil, your phaco part is easy, and final axis alignment of the IOL will be easier. So before marking the axis, you should know the alignment of the axis. That is, superior is always taken as 90 and left temporal is 0. Otherwise, clock hour 3 can be taken as 0. Before doing the axis marking, see the calculation sheet. Here the axis marked is 11 degree. And if there is any conjunctival ballooning, just swipe the fluid towards the fornix and clear it. And in this video, you can see, take the toric dial, keep it over the limbus, align it to the reference axis 0, 180, and take the marker marked with the junction violet and keep at 11 degree. The marking will be seen clearly, and if the cornea is not dried properly, you can see smudging like this or spreading of marking, which will be giving poor visualization during your phaco. To avoid parallax, the surgeon side marking is taken as the reference. You can do this procedure with your dialer also. Before making the pots, see the calculation sheet once more. See the incision location is at temporal side, that is on the surgeon side. Here it is on 0 degree, and the alignment axis is given. Better take any clock hour position other than the alignment axis for making a side port. If you make side port at the alignment position, then after hydration, the visualization of toric markings will be difficult. And always see the alignment axis is plus or minus 10 degree from the steep axis. If you are putting somewhere near the flat axis, you will be adding on the cylinder. In the calculation sheet, always verify the patient's name and the eye and the remaining IOL power, that is the toric power remaining. Here in this video, you can just make the pots just like any other case of phaco. Just only one thing to be careful, avoid the alignment axis. Rhexis is just like any other case. Do a 5 to 5.5 mm rhexis. It will be covering 1 to 1 mm of the periphery of the lens, and it will be giving a proper centration of the lens and will prevent prevent rotation for the lens. After completing the Rexis, for hydro, it's a routine hydro. You can rotate the lens. You can do the phaco procedure of your own choice, that is chop and chop, divide and conquer, or direct chop, whichever is your preferred choice. Once you complete with your phaco, you can do a complete cortical cleanup. After doing the complete cortical cleanup, you can implant the IOL either under visco or under IA. Before putting the IOL inside, you should know the systems available for torics. The first one is a Technis iHands preloaded IOL, which is the instruction will be provided by the manufacturer. The second one is Indian system, that is Suprafob toric IOL. Non-preloaded ones also are available. They are to be loaded as per the instruction provided by the manufacturer. It can be loaded just like any other monofocal IOL of the same manufacturer. Should be placed inside the cartridge as per the instruction, and the cartridge has to be fitted into the injector system, and you can check the movement of the lens by pushing the plunger. If it is moving properly, then it is ready for injection. This is a Indian system Suprafob that is loaded as per the instruction. This is not playing. Through the nozzle, saline has to be injected, and visco has to be injected through the nozzle and from behind. The flaps you can see that has to be closed by removing the central flap separator. Once it is ready, you can check the movement of the lens by pushing the plunger. For implantation, you can either proceed with a wound-assisted implantation or as normal implantation. Once it is there inside the AC, the front haptic has to be inside the bag. The back haptic, that is the trailing haptic, has to be folded and kept inside the AC. Once it is inside the bag. Once it is inside the bag, you can rotate it at the optic haptic junction with your dialer to the desired axis. This is a square plate IOL which is implanted. The leading end of the plate has to be placed inside the bag, and the trailing end, let it be in the AC. And you can dial it from there to the needed axis, and after that, once you reach the needed axis, you can rotate it. You can rotate it to the needed axis, then just press it and keep inside the bag. Once it is inside the bag, just see the IOL marking is in alignment with your corneal marking. Once you complete the IOL implantation and rotation to the desired axis, next thing is the visco wash. Do it completely, and with your aspiration cannula, you can just slide the IOL to one side, and through the gap you can keep your aspiration cannula just under the IOL. Swipe under the IOL and do a complete cortical wash, complete visco wash. Once it is completely free of visco, you can just tap the center of the IOL so that it will be little bit adherent to the PC, that is bioadherence will be enhanced. For easy rotation for a C-loop IOL, you can just with your dialer you can hook at the optic haptic junction, pull slightly towards the center and rotate it to the desired axis. For a plate haptic IOL, it's better to rotate it partly when it is in the AC and partly in the bag, and once it reaches the desired axis, you can just press it and keep it inside. There's a dialing hole provided for the rotation. Once you complete this, you do a gentle port hydration without causing any further rotation to the lens. Once you complete with your toric IOL surgery, just once more you verify your axis is correct. Take the toric dial once more, keep it over the limbus in alignment with the 0180 reference marking, and check the IOL toric marking is in alignment with your corneal marking, and that is in alignment with your toric dial marking. And as described earlier, the digital system also is available very on. It will show you that this triangle is the incision location, and the alignment axis also will be shown intraoperatively and postoperatively. You can verify with this. Thank you.
Thank you, Seena, for that wonderful videos. Now we have implanted the IOL, and now we'll see next post-op day what is happening. I invite Dr. Jashina to give her talk on post-op assessment. Jashina is a phacosurgeon at Comptress Eye Hospital. All of us are colleagues there.
Good evening. My colleagues already explained about the patient selection, patient workup, patient education, and IOL implantation. My topic is post-operative management. Even after uneventful post-op, most of the 70% of the patients, only 70% of the patients will be happy. Remaining 30% of the patients have some form of remaining refractive error. So, how will proceed? In happy patients, we have to check uncorrected visual acuity and best correct visual acuity, whether they have achieved targeted vision, expected target vision. Then we have to dilate and see under slit lamp examination. Look for anterior capsule rhexis cover over the IOL. Look for the gross centration of the IOL by comparing the toric IOL marks with the pre-op implantation axis sheet as reference. There is no need for look for minute degree to degree alignment. Many slit lamp can tilt the measure and thin slit beam of the light, which can be aligned with the toric markings, that is dots on the IOL optic, to estimate where the IOL is now oriented. You can turn the slit lamp to thin slit beam of the light to align the IOL marking. So, patient IOL is aligned at 180 degree. Then coming to the unhappy patients, so we have to check the vision and best corrected vision and acuity, and also accurate subjective and objective refraction. Then slit lamp examination to verify the axis, whether it is in the targeted position or not. And repeat keratometry, biometry, and IOL power calculation. Then if axis is as planned, but there is astigmatism is there, then it may be due to poor or incorrect biometry, or uncorrected for posterior corneal astigmatism, or it may be due to wrong IOL, or it may be due to surgically induced astigmatism. So there are online calculators available like astigmatismfix.com, iTrace, or Barrett RX Analyzer, or assort.com. Then how will check in the astigmatismfix.com? We have to enter the doctors and patient data and which eye and the IOL power and current refractive status of the patient, and also the IOL power and model, and then click the calculate. Then we'll get the picture like this. Here the patient IOL was oriented in 28 degree, and now it is there is some error was there, so it have to rotate 12 degree. Then coming to another case scenario, here the optometrist flipped down the axis. Actually, her K1, K2 was K1 was 41.2D at 89, and K2 was 47.2. She flipped the axis in the toric calculator, and the axis code was at 89 degree. But after follow-up, patient UCVA was 624 and BCA was 66 with plus 2.75 and minus 0.5 D at 90 degree. So when put the data in the astigmatismfix.com, the axis was not in 90 degree. It is actually, it has to be redialed to 180 degree. So realignment of the toric IOL is needed in cases more than 10 degree of rotation from the target axis. A rotation of less than 10 degree changes the manifest refraction only by 0.5 degree diopter and usually does not warrant any additional intervention. For every one rotation, 3.3% of the lens cylinder power calculation is lost. For 30 degree rotation, there is complete loss of astigmatis error correction, and more than 30 degree additional astigmatism or visual problem will develop. When we will do redial, only after 1 week is ideal, otherwise re-rotation will occur. So here there is one patient with 67-year-old male patient. His K1 was 39 at 86 and at 86 degree. K2 was 41.6 at 178 and axillary, and IOL power was 20 point D. First day his vision was 6.6. 1 week he came with vision was reduced to 6/24 and his BCA was 6.6 with this correction. So his initial IOL we calculated in the Alcon online calculator. It was 177 degree, but it was on was 1 week when he came. It was at 130 degree, and when it's checked, we have to rotate to 179 degree. So how will rotate? First we have to inject cohesive visco, then we have to make ensure that there is no adhesion between the capsule and IOL, then dial in clockwise direction till up to less short of 10 degree of the target axis. Then wash the visco and final adjustment or refine with either irrigation probe or you can use dialer to fine adjustment. Then giving a central tap also give a addition at the center. Then hydrate the wound tightly so that IOP is slightly higher than normal, and it will prevent further rotation. Then what is the importance of subjective refraction? We can calculate the spherical equivalent error. Here the spherical equivalent is error is 0.25. So if more than 1 degree, 1 diopter only, we have to do for IOL exchange. Otherwise always rotation is preferable. Sometimes IOL rotation or exchange may not be helpful to make patients happy. Glasses or PRK or piggyback IOL may be needed. So take home messages, always compare with pre-op UCVA. If the patient is having bilateral cataract, in the post-op cover the operated eye and show the vision in the unoperated eye first, then show the vision with the operated eye. This will help giving the wow factor to the patient. Any realignment of the IOL to be done after 1 week or usually 2 to 3 weeks. After 8 weeks, it is difficult to realign because of the fibrosis of the capsule. So after giving, after a good post-op and patient is getting a 6.6 vision without glass, patients will be happy. We will also happy. Thank you.
Thank you, Jashina, for the troubleshooting mechanisms in toric IOLs. Now I invite Dr. Vijayalakshmi for the special situations to discuss on.
Good evening all. Okay. Now we have implanted in a routine cases toric IOL. Now there are some certain situations whether we are in a dilemma whether this patient is going to benefit from a toric IOL or is it appropriate for the patient to have a toric IOL implanted. So we'll just see some case scenarios. Now this 26-year-old man had undergone RD surgery following blunt trauma, and he comes back after 5 years with a defective vision of 6/36, and he had a posterior subcapsular cataract. So what is the problem is the patient has an encerclage done, and it is an equatorial position is a buckle. It's an encerclage, it's going to be a permanent thing. So if this patient is going to benefit from this toric IOL is our question. Since it is going to be a permanent, there is no harm in doing a implanting a toric IOL for this patient. Actually, his point right now. Actually, this patient has got toricity in both the eyes, and you can see the increase in axial length after the buckle. If it's an encerclage, it is okay, but if there is a radially placed buckle, you should be careful because that can again increase the astigmatism. In those cases also, it is again going to be permanent. Repeat the biometry, and if you're getting repeatably the same toricity, you can go for IOL implantation. And so the take-home message from this is corneal astigmatism stable, can go for toric IOL implantation post-RD surgery cases. Now this is a patient with a penetrating injury and he's got aphakia. He's got a PC dehiscence in temporally with a PC rem nasally. So we had done a corneal suturing, and this is a patient's topography picture. You can see the flattening and the area of the suturing, and he's got an IOL power of 26 with a toricity of 2.36. He was a young man of 26 years. So we implanted a monofocal in the sulcus. Why? Because we are not supposed to implant a toric IOL in the sulcus has a chance of rotation. Not only that, I don't think there's available 3-piece toric IOLs also. Never implant a single piece in the sulcus. Now, in case of PCR, if it is central PCR, if you can do a PCC, you can place a toric IOL in the bag with the haptics in the bag and do an optic capture at the PCC. But beware when you are rotating, the PCR can get extended. Similarly, when there is zonular instability, if you can put a CTR, make the bag stable, only then go for a toric IOL implantation, or please go for a monofocal IOL implantation only. Now this is a 72-year-old female. She had undergone cataract surgery in right eye with 6/6 vision, and she had keratoconus in the left eye. So when it comes to keratoconus, you be very careful. You can see the ring image of the irregularity, and this was her PG power. Axis was at 90 degrees. But when we did the topography, you could see the axis was different, and she had about 9.47 of astigmatism, and this is her topography. So here the patient's topographically and biometrically the axis was same, but the acceptance was a different axis. So in such patients, we can implant a toric IOL with a word of caution telling them you can have a lesser of spectacle dependence, but we cannot predict the outcome in such cases. Thankfully, the patient herself requested me to go for a monofocal only, and she didn't want a toric IOL. So, and this was a post-op axis was again different. So in such patients, if a mild keratoconus and moderate keratoconus, if we have a central cone and repeatability of biometry is there, you can go ahead with toric IOL implantation. But if the K value is more than 50, it is better go for monofocal implantation. Now there's a young man with 22-year-old and bilateral keratoconus, undergone C3 2 years back. Patient developed posterior subcapsular cataract, and this was a patient's toricity. You can 6-cylinder in right eye and 8-cylinder in the left eye. So we told him we can go for a toric IOL implantation, but there can be a residual power remaining. You will have to go for a contact lens or glasses, whichever is acceptable. Since he had so much of toricity, we went for a toric IOL implantation for this patient, and he had a stable biometry and stable topography. So, and we made a custom-made lens of 7 and 6 diopter cylinder at the IOL plane, and the residual was corrected with a contact lens. So in keratoconus, as I mentioned earlier, with stable refraction, we can implant toric IOL and reduce the spectacle dependence and improve the vision. Now the 73-year-old male, he had come to a hospital for cataract surgery, and this was a K1 and K2, and this was axial length, but the Sherma was 0. And you can see the irregular Myers. So we, after using of lubricants, we could see the change in the keratometry value. And with this K value, we implanted the IOL, and the patient was happy, and the post-op vision was 6/6. So dryness is something which has to be addressed. The ocular surface should be addressed, and you must get a repeat and repeat biometry and plan accordingly. It should be very much repeatable, the biometry as well as the topography. Now, in case of rheumatoid arthritis, this patient had a PUK scar. So initially when we did the cataract surgery, she didn't have much of she had a cylinder but not much of toricity. So what we did was we implanted monofocal toric for this patient. Why? Because rheumatoid arthritis, there can be peripheral thinning and scarring, which is an ongoing process. So in such cases, better to go for a monofocal IOL only. So you can see the change. I don't have the first one. So you can see the change in the IOL power. Here you can see the cylinder is increasing. So in such patients, go for a monofocal IOL only. So when you come to central corneal opacity, always check the pupil cornea corresponding to the pupil. If it is regular, that's important. If it is regular, you go for a toric IOL implantation. If the regularity is not there, please go for a monofocal IOL implantation. Let the scar be in the periphery. Again, check for the regularity at the pupillary area, cornea corresponding pupillary area, only then go for an IOL implantation. In this case, though it was not, it was 134 and 44, since it was encroaching the pupillar area, we went for a monofocal IOL implantation. Patient had only so much of cylinder. Now, this patient had undergone LASIK, patient developed ectasia, patient underwent phakic IOL implantation, and patient had come with NS3 cataract. So, we did an phakic IOL explantation and we did a cataract surgery, and this was a patient's best corrected visual acuity when he came to us. So, and this is a patient's topography picture. You can see the flattening following the LASIK procedure and posterior ectasia, and we implanted a two spherical equivalent of 2 and cylinder of almost 6 in the IOL plane, and the patient vision improved to 6/18. In all these cases, we can implant toric with a word of caution only. And this is another patient who had bilateral pterygium and both nasal and temporal. Patient underwent pterygium surgery. He came to us only after 6 months. So we had a repeated topo cylinder which was stable, and then we went for a toric IOL implantation. Again, it's very important, check for the repeatability. And the post-op patient was very happy. So in word of multifocal IOLs, when there is a cylinder power of more than 0.75, always go for a multifocal toric, or the patient will never be happy. And similarly, when you have a small pupil, toric IOL implant is very difficult. So initially, better avoid such cases. Later on, if you are very confident, you can use irrigation port and then use the dialer in the other hand and make sure the axis is aligned properly. This is a patient Dr. Sugandha had mentioned earlier, 42-year-old male. This was his retinoscopy values, you can see, and this was his IOL port is 29, and there was toricity also. We would implanted a toric IOL, but the patient was not happy, though his vision improved from 2/6 to 6/36, and even with the caution we had implanted, patient was not happy. So, word of that amblyopia should be mentioned to such patients whom we have so much of hyperopic correction in the wet retinoscopy itself. Thank you.
Thank you, madam, for highlighting all the cases which we come across once in a while during our practice. Thank you.